Welcome back to the Depth Dive. Today we're going to get into a condition that, well, it comes up a lot and it's really key to understand. Bacterial vaginosis, or BV.
Yeah, that's right.
Think of this as us helping you really nail down the absolute essentials about BV, maybe for revision or just for a clearer picture. We've looked through the guidelines, things like bacterial vaginosis, overview, diagnosis, and management, to pull out what you really need to know.
Yeah, the high-yield stuff.
Exactly. What it is, what causes it, the risks, how it actually works biologically, what else it might look like.
Who gets it, how it shows up.
How it's diagnosed, treated, the outlook, and any potential problems down the line. Basically, your shortcut to feeling confident about BV.
Okay, let's jump in. So bacterial vaginosis, at its heart, it's a really common vaginal condition. It happens when the normal bacterial balance in the vagina gets, well, thrown off.
Thrown off.
Yeah, you get an overgrowth of certain types of bacteria. Gardnerella vaginalis is the name you hear most often. And at the same time, a drop in the good guys, the lactobacillus bacteria that are normally there.
Okay, so the beneficial bacteria decrease and these other ones increase. And that imbalance messes with the vaginal environment, like the acidity.
Precisely. That change in balance alters the vaginal pH, makes it less acidic.
Yeah.
And that shift leads to the symptoms we often see, and sometimes other complications too.
And you said it's common.
Incredibly common. It's actually the #1 cause of abnormal vaginal discharge for women of reproductive age.
Oh, okay. So a quick way to remember the core issue.
I like balance broken, bacteria booming.
Balance broken, bacteria booming. Got it. Okay, so what actually causes this bacterial booming? What's the etiology here?
Well, it fundamentally comes down to that overgrowth of what we call anaerobic organisms. Gardnerella vaginalis, yes, but also others like Prevotella species, Mycoplasma hominis, Mobiluncus.
A whole bunch of them then.
Yeah, a mix. And the mechanism is key. They basically take the place of the lactobacilli. Now, lactobacilli usually keep the vagina acidic, a pH below 4.5.
Right.
But when their numbers drop, the pH starts to climb, often up to around 6. And this less acidic environment is much better for those anaerobic bacteria to thrive in.
I see. So the environment changes, allowing these others to flourish. Now, we often hear BV mentioned alongside sexual activity, but it's not technically an STI, is it?
That's a really important point.
Yeah.
No, it's not classified as a sexually transmitted infection. However, it is more common in people who are sexually active.
Okay.
Things like having a new sexual partner, for instance, seem to increase the risk. But other factors play a role too. Hormonal changes, anything that might alter that vaginal pH can contribute.
Right. Okay. So speaking of risk, who is more likely to experience this bacterial shift? What are the main risk factors you should be aware of?
Okay, there's a fair few. Sexual activity, like we said, particularly with a new partner. Having other STIs is also a risk factor. Ethnicity seems to play a role.
Right.
There's a higher incidence noted in Afro-Caribbean women, though the reasons aren't totally clear.
Interesting.
Using a copper IUD, the coil, that's another one. Vaginal douching is a big one, definitely discouraged.
Right, that makes sense, disrupting the balance.
Exactly. Also using bubble baths, receptive oral sex, and even smoking have all been linked to a higher risk of BV.
Wow, quite a list. Is there anything on the flip side, factors that might actually protect against developing BV?
Yes, there are. The combined oral contraceptive pill seems to help because it encourages those helpful lactobacilli.
Ah.
Using condoms is protective. And having a partner who is circumcised is also associated with a lower risk.
Good to know.
But again, just to really hammer it home, despite these links to sexual activity, BV itself isn't considered sexually transmitted.
Gotcha. Maybe a mnemonic could help here.
Yeah, you could try something like sexual new STIs, ethnic copper, douche bubble, oral smoke, risk.
Okay.
And for the protective side, pill condom circumcised.
Right.
Protected.
Great, thanks. So we understand what happens if the balance breaks down, but how does that actually lead to symptoms? Or sometimes no symptoms? What's the pathophysiology?
So the how flows directly from that imbalance. You've got fewer lactobacilli and more Gardnerella and friends.
Right.
This leads straight to that higher vaginal pH we mentioned.
Right.
But it also means less hydrogen peroxide is being produced. Lactobacilli normally make this, and it helps control other bacteria.
Oh, okay, so less natural antiseptic, kind of.
Yeah, in a way. And at the same time, these anaerobic bacteria, as they break down proteins, produce compounds called amines. Things like cadaverine, putrescine.
Oh, those names sound familiar.
They do, don't they? And it's these amines that cause that characteristic fishy odor associated with BV. So it's this whole cascade. Fewer good guys, More other guys, higher pH, less peroxide, more smelly amines.
Makes sense. It's like a chain reaction.
Exactly. You could maybe think of the vagina like a garden. Lactobacilli are the helpful gardeners, keeping weeds, the other bacteria, under control. In BV, the weeds sort of take over, change the soil pH, make a bit of a mess, and, well, produce those odors.
That's a really helpful analogy, the garden gone wild. Okay, so someone comes in with symptoms suggesting this. What else could be going on? What are the differential diagnoses we need to keep in mind?
That's crucial because vaginal discharge doesn't automatically mean BV. You absolutely have to consider other things.
Like what?
Other infections, definitely. So candidiasis, thrush, or yeast infection, that's common. Trichomoniasis, which is an STI. And other STIs like chlamydia, gonorrhea, even herpes simplex can sometimes present with discharge.
Okay, so other infections are high on the list.
Yes. But also non-infectious causes, just normal physiological discharge, which varies. Irritation from soaps, spermicides, douches, maybe a forgotten tampon or other foreign body. Changes related to pregnancy can cause discharge, or something called cervical ectropion. Less commonly, you might think about tumors, vulva, vagina, cervix, endometrium.
Okay, less common but important not to miss.
Definitely. And in postmenopausal women, discharge could be from atrophic vaginitis, or it could happen after some types of gynecological surgery. So the list is quite broad. You need to think widely.
Absolutely. So thinking about the bigger picture, how widespread is BV? What's the epidemiology look like?
It's very common. Here in the UK, estimates suggest around 20 to 30% of women of reproductive age are affected.
1 in 3 or 4 potentially. That's significant.
It really is. And the prevalence varies depending on the group. For example, studies might find it in about 5% of, say, college students who aren't sexually active.
Okay.
But that jumps to maybe 12% in pregnant women, and it can be as high as 30% in women attending clinics for termination of pregnancy.
Wow, quite a range.
Yeah, and as we've touched on, it is generally more common in those who are sexually active. Hence, that term sexually associated sometimes gets used.
Right.
There's also some data suggesting it might be more prevalent in women who have sex with women, but there could be other factors involved there that need more research. The main point is it's widespread, but the rates aren't uniform across all groups.
Okay, so it's common but variable. If someone does have BV, what are the classic signs and symptoms? What are the clinical features?
Well, the textbook features are that thin, grayish-white vaginal discharge. It's often described as quite homogeneous.
Okay.
And that distinct fishy odor, remember the amines, that odor is often more noticeable after sex or during a period.
Right, because blood and semen are alkaline, they'd raise the pH further.
Exactly, which releases more of those volatile amines. Some women might get itching or irritation, but honestly that's less common than with something like thrush, maybe a burning sensation when peeing sometimes too.
Okay.
And this is really key for anyone revising. About half of women with BV have no symptoms at all. 0. They're asymptomatic.
50%. Wow, so
Yeah.
it could just be picked up incidentally.
Yes, or during screening for other things. If there is an examination, you might see that thin white discharge coating the vaginal walls.
Any memory tips for the features?
How about gray, fishy, sometimes itchy, burny, often nothing?
Gray, fishy, sometimes itchy, burny, often nothing. I like it. So given it can be asymptomatic or have varied symptoms, how do we actually confirm a diagnosis? What investigations are done?
Often the diagnosis starts with the clinical picture, the symptoms, and the history.
Yeah.
A pelvic exam is usually done to look at the discharge and check the vaginal pH. A pH above 4.5 is a pointer towards BV.
Just a pointer, though.
Yeah, because as we said, other things like trichomoniasis can also raise the pH.
Yeah.
But the gold standard really is using Amsel's criteria.
Amsel's criteria. Okay, what does that involve?
You need 3 out of 4 specific things. 1, that thin, white, homogeneous discharge we described. 2, seeing clue cells under the microscope.
Clues?
Yeah, these are vaginal epithelial cells, the normal cells lining the vagina, but they look kind of fuzzy or stippled around the edges because they're covered in bacteria, mostly bacilli.
Ah, okay. So that's clue number 2.
Exactly. 3, vaginal pH greater than 4.5. And 4, a positive whiff test.
Whiff test. Sounds appealing.
Yeah. You add a drop of potassium hydroxide solution, KOH, to the vaginal discharge sample, and if it releases that fishy amine odor, the test is positive.
Okay, so 3 out of those 4 seals the deal for Amsel's.
Pretty much. And related to the microscopy part, there's also the Eisenhay criteria, which grades the microscopic appearance based on the bacteria seen. Grade 1 is normal, mostly lactobacilli. Grade 2 is intermediate. And grade 3 indicates BV, lots of other bacteria, very few or no lactobacilli.
So that gives a more detailed microscopic picture.
Yes, but it's important to stress just finding Gardnerella vaginalis bacteria on a culture doesn't automatically mean BV. Lots of women have it as part of their normal flora without any imbalance or symptoms.
Right, context is key. Can treatment ever be started without all these tests?
Sometimes, yes. What's called empirical diagnosis and treatment might happen if someone has really typical symptoms. They're considered low risk for STIs, no new partner recently, haven't just been treated for BV. In that scenario, a clinician might treat based on the symptoms.
Okay, and that pH test, how's that done?
Usually with pH paper. You take a swab from the side wall of the vagina, avoid the cervix as cervical mucus has a different pH, touch it to the pH paper, and compare the color change to the chart.
Got it. So maybe an example question for listeners.
Sure. What are the 4 components of Amsel's criteria that help diagnose BV? Thinking about discharge, clue cells, pH, and whiff test.
Perfect. So let's say BV is diagnosed. How do we manage it? What are the treatments?
The standard approach is antibiotics. Oral metronidazole is the most common choice, usually for about 5 to 7 days.
Metronidazole. Okay.
There are also topical options, gels or creams applied directly into the vagina, like metronidazole gel or clindamycin cream. Those can be good alternatives if someone prefers not to take oral meds or has side effects.
Are they equally effective?
Generally considered similarly effective for the initial cure. Now, really important advice alongside treatment is to avoid vaginal douching. We know that disrupts the normal flora. Good general hygiene is helpful too, of course.
And what about treating women who are asymptomatic? You said half don't have symptoms?
Generally, no. If someone has no symptoms, treatment usually isn't recommended unless they are pregnant or about to undergo a termination of pregnancy.
Why the exception then?
Because in those situations, BV is linked to a higher risk of complications, like preterm birth or post-procedure infection. So treatment is advised then.
Okay, that makes sense. If someone is treated and symptoms clear up, do they need follow-up tests?
Usually not unless they're pregnant. If symptoms resolve, that's generally considered a cure. One practical point. Vaginal creams and gels, especially oil-based ones, can potentially weaken latex condoms. So that's important patient advice.
Good point. And does the partner need treatment?
No, partner screening and treatment aren't routinely recommended for BV. It's not managed like an STI in that sense.
Right. Now, what about the issue of it coming back? Recurrent BV. That seems to be a common problem.
It is, unfortunately. Recurrence rates are high. More than half of women might get it back within just 3 months after treatment. It can be really frustrating.
So what can be done then?
For managing recurrent BV, sometimes longer courses of treatment or maintenance therapy are tried. For example, using metronidazole gel, maybe twice a week for several months, might help prevent it coming back in some women.
Okay, preventative use.
Yes. And there's a newer treatment called astrodrimer gel, which is specifically licensed for preventing BV recurrence. It works differently. It's not an antibiotic, but it stops bacteria from attaching to the vaginal wall and forming biofilms.
Biofilms, like protective shields for the bacteria.
Exactly. Those can make infections harder to clear and more likely to return. Astrodrimer gel disrupts these. Studies have shown it can reduce recurrence rates and provide rapid symptom relief. It seems well tolerated too.
Interesting. What about things like probiotics? You hear about those for vaginal health?
Yeah, there's a lot of interest, but the evidence for probiotics in treating or preventing BV is still pretty limited or mixed. More research is needed there.
So the mainstays are antibiotics, possibly maintenance therapy, and maybe this astrodrimer gel for prevention.
That sums it up pretty well. The key is always discussing the options with a healthcare provider to figure out the best plan for that individual.
Maybe a memory prompt for treatment.
How about Metro or Clinic to Clear? Avoid douche to dodge.
Metro or Clinic to Clear, avoid douche to dodge. Nice and simple.
Okay, so what's the general outlook for someone who gets BV? What's the prognosis?
Overall, BV is usually considered benign. It's not typically dangerous in itself, and sometimes it can even clear up on its own without any intervention. But as we just discussed, the big issue is recurrence. Even with successful treatment, it can come back quite often. Some figures suggest up to 70% recurrence within 3 months. So managing expectations about that is important. Right, so not serious in itself generally, but often persistent or recurring. Are there any potential complications we should know about beyond the symptoms themselves?
Yes, while BV itself isn't usually a major illness, it is associated with some increased risks.
Such as?
Well, having BV seems to make women more susceptible to acquiring HIV if exposed, and also potentially easier to transmit HIV if they have it. It's also linked to an increased risk of getting other STIs.
Okay, so increased vulnerability to other infections.
Correct. And then there are the pregnancy-related complications we touched on earlier. BV during pregnancy is associated with a higher risk of things like late miscarriage, premature birth, membranes rupturing early, the baby having a low birth weight.
Serious potential outcomes then?
Yes. And also postpartum endometritis, which is an infection of the womb lining after delivery.
So those pregnancy links are really significant. Does that mean all pregnant women should be screened?
Actually, no. Routine screening for BV in all pregnant women isn't currently recommended based on the evidence. Treatment of asymptomatic BV in pregnancy hasn't consistently shown a reduction in preterm birth rates in large studies. However, if a pregnant woman has symptoms, she should definitely be assessed and treated. It's more about individual assessment.
I see. So it's important to be aware of these potential consequences, especially in pregnancy, even if universal screening isn't the approach.
Absolutely. Untreated symptomatic BV can have these downstream risks.
Okay, so let's try and summarize this deep dive on bacterial vaginosis. We've established it's super common. It's fundamentally an imbalance in the vaginal bacteria.
Not strictly an STI, but definitely linked with sexual activity and other factors.
It has those characteristic features, the gray discharge, the fishy odor, but often, maybe half the time, no symptoms at all.
Right. And diagnosis relies on clinical signs, plus tools like Amsel's criteria looking at discharge, pH, clue cells, and the whiff test.
Treatment is usually straightforward with antibiotics like metronidazole or clindamycin, either oral or topical.
But recurrence is a really common headache. Avoid douching. Partner treatment usually isn't needed.
And while often benign, it's linked to increased STI risk and, importantly, potential complications in pregnancy.
Exactly. Hopefully running through those key points helps solidify it for your revision.
Definitely. We hope this focused run-through helps you feel more confident recalling the crucial details about BV.
Absolutely. And remember, if you're looking for more revision tools and resources, do check out PassThemSRA.com.
And FreeMSRA.com as well.
Great resources there.
So maybe one final thought to leave you mulling over. Given how incredibly common BV is, and these links to potentially serious outcomes like preterm birth or increased STI transmission, what area of research do you think holds the most promise for really making a difference to women's health regarding BV in the future?
That's a big question. Lots of possibilities.
Something to think about. Thanks for joining us for this deep dive.